Tiffany didn't. What? What? Wait a second. I gotta do this. So that. Okay. Now it's recording. Okay. Is it recording? I remembered. Okay. Hi. Hello, everyone. Welcome to. What are we doing again? Welcome to Live with Dr. S.
There you go. Like, what are we called?
I know. Live from Interventional Vascular Care. Come closer. Abby does the same thing. She was half off the screen the entire time last time. Hi! Hi, welcome. I'm Dr. S, Dr. Sclafani, and this is IOR Interventional Vascular Care. We are live from beautiful Garden City, New York.
I forgot to introduce me.
I didn't forget. I'm kidding.
This is Noodles.
Noodles. And Abby's hiding. Come say hello. Abby,
She's like, hi, people.
hi. Talk live world. She's hiding in the background. So today we are going to talk about
Drum roll.
Okay, yeah. No, we're being silly now. All right, today we're going to talk about vascular health, hormones, and pelvic congestion syndrome. All right, Noodles.
Oh my god. Might kill me on this one.
No, not gonna. We're gonna okay, so we kind of touched on vascular health before when we talked about varicose veins, right?
Yeah, that's true.
So, but now we're gonna talk about vascular health in a different way, and specifically how it affects women, because this is a woman issue. I mean, men, of course, they, vascular health, et cetera, but this is a specific woman problem that is quite frequently overlooked and misdiagnosed or undiagnosed, and it can really affect a woman's quality of life. So, have you ever wondered at all why pregnancy or hormones can change your veins and even cause chronic pelvic pain?
Everything changes once you're pregnant.
This is true. Do you know that babies eat you from the inside out?
No.
They do.
I want kids, and now you're making me not want them anymore.
It's the truth. That's what the baby's doing. It's sucking the calcium out of your bones.
Oh, yeah. I know that. I thought they were, eating, physically,
They're not physically eating.
Oh, yeah, why are they having some placenta?
Anyway, so yeah, pregnancy, menopause, birth control, all of these things, because they adjust your hormones or your hormones become adjusted during that time period, can affect your veins and your circulation, which is not something that we would normally think about. What is this nonsense? So many things on my computer. Okay. Hi, Patricia. How are you? Noodle.
Hi.
Yeah.
Hello.
You're supposed to say hello to everybody.
Hi, Patricia.
You haven't been here for 2 weeks and you've forgotten your job. If not, Abby's going to have to come in and say hello to everyone. Abby should just sit behind us and wave at everybody. Okay. Anyway, so tonight we're going to talk about hormones and how they affect your vascular health and why this matters and what it has to do with pelvic congestion syndrome and what exactly pelvic congestion syndrome is, which technically pelvic congestion syndrome is now called Pelvic Venous Insufficiency. Mm-hmm. Hi, Emma. She's our favorite patient.
Thank you for the.
I'm not supposed to play favorites. Anyway, it's technically called pelvic venous insufficiency now, but everybody still knows it as pelvic congestion syndrome. So, any of you vascular surgeons or IRs or doctors out there who are going to get annoyed because I still call it pelvic congestion syndrome, I know what the real name is. Relax. Anyway,
you can noodles.
You can noodles. So, but everybody still knows it as pelvic congestion syndrome, so that's why we're just short. But it's technically pelvic venous insufficiency. Anyway, vascular health. What is vascular health?
Really? Circulation?
Yeah, I know. These are
kind of a dumb question, but maybe it might not be that dumb.
These are low-hanging fruit questions.
Okay.
So arteries and veins, it's how blood moves through our bodies. Veins, they're low pressure, so they rely on valves, right? We did talk about all this. Oh, hi. Hi, Sophia. Hi, Joey. And Jay So Grace Ann's there. Bean, are you there, Bean? Say hi. So we talked about this when we talked about varicose veins. So veins work on a valve system, right? So that's how blood gets back. Blood goes up, veins open, they close. When the veins start to not work properly and they kind of hang open, that's when you get the blood that pulls back. Arteries work by your heart pumping, so they're high pressure. So they're more solid. Yeah. They're more solid, and they keep their shape better versus veins that like squish down. So, when the valves stop working and the blood pools, the veins will expand and they'll dilate. And that's when we get those varicose veins and stuff, which we talked about last time. So how do hormones affect veins? Do you know how hormones affect veins?
No, I actually don't. Because they're two like different things.
So yes, but like our hormones affect everything in our body, right? So our hormones kind of play a role in everything, right? So hormones, specifically for women, estrogen and progesterone, which is what we produce, when we're in our childbearing years, and then later on menopause, we don't have so much estrogen. But then also nowadays, women use birth control pills, which are hormones, right?
Okay.
And that's how you control yourself from not ovulating. So, but those hormones, they have effects on our body. So estrogen and progesterone, they actually make veins more elastic. And so it leads to dilation and the valves can weaken. So not that I'm saying you should stop your birth control because of your veins. There's other ways to take care of your vein health. Birth control is important. So, but that's what, it doesn't happen to everybody, but that's what can happen when you have like too much of those hormones around. So, and how this affects us is because people who are predisposed to having venous insufficiency, whether it's in your legs or in your pelvis or something, when you introduce these other hormones, it could lead to these problems. So does that make sense?
Yes.
And so that's why a lot of times what will happen is if somebody is prone to venous insufficiency, it will show itself at certain times in life. So puberty, right?
Yeah.
Because surge of hormones. And now you never had any problems before, and then you had this surge of hormones, and now your veins become an issue because all of a sudden all these hormones are in your body that weren't there before, right? Pregnancy, you get vein changes, and that's for multiple reasons. Again, hormones, and the hormones make the veins more elastic. But then also
menopause. I was like, I know this one was coming back.
Menopause is always, it's whenever in doubt, just say menopause. So it's just so mean. Nature's little joke on us women. No, so the baby, do you know that your blood volume increases by 30 to 50% when you're pregnant?
No.
Yeah. Because of the baby.
No, because you have to supply the other one in there.
So your actual blood volume increases by 30 to 50%. And because of that increased blood volume, it puts pressure on everything. That's why a lot of women, when they're pregnant, they're told to wear compression stockings, because a lot of women will develop the varicose veins during pregnancy.
That makes sense,
Because not just the hormone, but also, decreased mobility when you get later on in the pregnancy, and then also, the increased blood volume. Mm-hmm. So pregnancy, again, so you can get leg varicose veins during pregnancy or after pregnancy, vulvar varicosities.
Yeah.
And then pelvic congestion syndrome, pelvic venous insufficiency, right? Which we will talk about what that is, because I'm sure there are people out there that have never heard of it and are wondering what I'm talking about. We're going to get there, I promise. And then again, so birth control. Estrogen, which is part of contraception.
Yes.
That can also, that birth control can increase your risk of blood clots, right?
No, I did not. This is why I don't take it.
I mean, no, that's why
I look like an Oompa Loompa because of the birth control. It wasn't because of the birth clot.
You always call yourself an Oompa Loompa.
Well, I look like an Oompa. Well, I used to. Tiffany looks great. I know we look great. Why you look like an Oompa Loompa?
Look like an Oompa Loompa. You're so silly.
You would have put me right next to a balloon and we would have been the same thing.
No, it's a legitimate concern. Like I've known people in the past, and I know people who wouldn't take birth control because they were worried about blood clots. They were also smokers. So anybody out there who is on oral contraception, if you are a smoker, please don't smoke, because that's like a double increase in the risk of getting a blood clot. So, but anyway, yes, estrogen predisposes you to blood clots, and that's in contraception. So that's why if you can get on a contraception that is progesterone alone, that tends to be safer in the blood clot risk than having a combination of estrogen progesterone. So, but again, say smoking, obesity, these are all history of DVT. These are all risks, and then of course, menopause. Menopause is a drop in estrogen, and that actually causes a loss of the protective effects of estrogen on the vessel walls. So, and then again, as you get older, you get collagen changes. We all talk about our skin and our face.
And avoid the sun.
And avoid the sun. Well, yeah,
I figured it was coming, so I'd rather just say it.
You know me, I'm like a broken record about SPF. Yeah. So, but the loss of the collagen affects our veins too. And so
we have a question.
Oh, we do. Okay. So, do your vessels contract when you go through menopause? No, they don't contract, but no, they don't contract. It's an annoying when you get a surge in estrogen, the estrogen affects your vessels, and then also when you have a decrease in estrogen in menopause, it affects your vessels. So, but then when you go through menopause, there's also the collagen changes also. So they don't contract. Veins will never contract. Once veins dilate, they won't contract.
Yeah, it's only the arteries and shit.
Well, no, arteries naturally dilate and contract because that's how we control our blood pressure. Mm-hmm. So unfortunately, if say you have varicose veins in your legs and then you go through menopause, it's not like those varicose veins are going to contract and go back to normal. Once they're there. Right. Think of it as like, what's a good analogy? I'm trying to think, what's a good analogy? Something that stretches out and then just will never go back to its normal shape once it's stretched. Anybody?
No. I was thinking, you know how they compare if you break my car, it's like a paper, once you crumpled it, you can't just make it
crumple it. Oh, make it smooth again?
Yeah, but that wouldn't really go with the vessels.
I'm trying to think of think of something, Abby. You know what I'm trying to say, right? I'm sorry. I'm trying to think
something stretchy that does not go back.
Right. That once you stretch it, it won't go back. Think of it ooh, how about this? Like an elastic waistband. Like once you stretch it out, it'll never go back to what it was.
Yeah, but that's after a few washes.
Well, yeah. I mean, your legs after a few washes, 20, 30, 40 years.
That's true. Yeah, that's true. We can do that. Not the greatest, but we can do that.
I'm doing my best.
It's better than my paper for sure.
See, Abby says it makes sense.
What's Abby? I don't know.
Oh yeah, wait.
I'm kidding. Everyone's walking home.
I got excited. Okay, so anyway, what are the symptoms? Well, okay. What are the symptoms of hormone-related vein changes? So basically what we talked about with varicose veins, leg heaviness or swelling, visible varicose veins or spider veins. Now we're going to start talking about pelvic congestion syndrome, but you'll get pelvic heaviness or aching, pain that worsens either in your legs or your pelvis for standing a long time or during menstruation. Because remember, menstruation, your hormones surge, and then that hormone surge will affect the veins. And you can also get labial varicosities.
I have a question.
Sure. So how ask me what a labial varicosity is?
No, I passed that. So how do you tell the difference between a uterine fibroid and pelvic congestion syndrome?
Oh, excellent question.
That's why I didn't pay attention. I didn't hear the rest of it. I was wait, how do you know the difference? Because it sounds like the same thing except for the heaviness.
Yes, it is frequently misdiagnosed, or it is. So like when you're a physician, when you're in medical school or whatnot, we're always taught to come up with differential diagnoses. So when somebody comes in, even if you kind of know what they have and what's going on, in your brain, you're supposed to go through, well, I think it's this, but it could be this, and it could be this, and it could be this. That's what a differential diagnosis is. So yeah, fibroids and pelvic congestion all kind of land in that differential diagnosis. The difference is with pelvic congestion syndrome, you'll get that same heaviness and aching and bloating in your pelvis, but it won't necessarily affect the quantity of your menstruation, your period. Whereas a fibroid, you will get really heavy, horrible period menstruation because those fibroids make you bleed a lot. So does that make sense? So that's like a way to differentiate the two. That is a great question because we are in July is National Fibroid Awareness, which we've spoken about fibroids before. If people wanted to, we can talk about fibroids again. But yes, that is in the differential. And quite frequently, patients who have pelvic congestion syndrome will get misdiagnosed with other things because unfortunately pelvic congestion syndrome is really, it's more of a recent diagnosis. Even though it's been going on for a long time. Right. You know, I always say as women, we're trained to live with chronic like pain every month. Yeah. You know, because we get our periods and menstruation. So there are women out there that have lived for years and years and years with, chronic pelvic pain and they think it's normal. And it's not normal. And it's kind of, they'll say it's a diagnosis of exclusion. They make sure everything else, it's not that until they come to this. But I think, the medical community needs to be more aware of it. I mean, there are some, it's just not on a lot of physicians' radar. Does that make sense? And it should be. Yeah, and it should be because it's not as uncommon as we think it is. Exactly. So symptoms, we talked about symptoms, general health tips to help with your veins, whether they're your legs or whatnot, stay active, avoid prolonged sitting or standing. If you are sitting for a long time, elevate legs or get up and move around like every couple of hours. I've said this before, sitting is the new smoking, you should get up and move around every couple of hours. Maintain a healthy weight. Weight affects your veins, especially in your legs. And then compression stockings, which should I try and get my leg up? Like show everyone the sock. My primary doctor says she never even heard of pelvic congestion. See, look at that. Or the other name. That's crazy. See, that's a primary care physician. Thank you for telling us that. That's so sad. It is. And unfortunately, we all need to go to medical school. Well, no, but it's like you go to your primary, right? And there are tons of people out there that they will go to their GYN, and I'm not knocking GYN, but they'll go to their GYN and they'll talk about their fibroids, and the GYN doctor will never tell them about uterine fibroid embolization. Because either they don't know about it or they don't know enough about it, and so they don't. So if you are having chronic pelvic pain and you're going to your physician and you're like, a lot of these women, they get desperate because they don't, imagine living with just chronic pain all the time. I mean, it would make me crazy. You know what I mean? It's like, and you can't find the source and you're going to physicians and you're trying to basically help me and they don't even know if they haven't even heard of it. Like, oh my goodness, what is going on? All right. We're still there. I don't know. We probably were still there, but my computer went funky. Anyway, we're back. So let's talk about, when to see a specialist if you're having these issues, chronic pelvic pain, leg swelling or heaviness, painful or bulging veins in your legs or anywhere else, prior blood clots or family of blood clots, because that could be a risk factor, especially if you have varicose veins, you can form blood clots. Mm-hmm. And then if you are considering hormone therapy, like OCPs, oral contraceptives, then you should definitely have a conversation with your physician if you have any sort of vascular history in your family or your own vascular history. Because like we said, estrogen and oral contraceptives can increase your risk for blood clots. So, all right, let's talk about the main topic today.
This wasn't the main topic?
Well, no, it is.
It's throwing me off.
It is the main topic. But I want to get to the really important topic, which is the pelvic congestion syndrome.
Oh, okay.
Because,
You're throwing me off.
No, I know. It was a huge lead up to like the pelvic congestion syndrome, also known as pelvic venous insufficiency, which is basically what are varicose veins? Venous insufficiency. So that is what pelvic congestion syndrome is. It is pelvic venous insufficiency. So basically, it is varicose veins in your pelvis.
Mm-hmm.
Okay.
Yep.
So, and there are women out there that'll have varicose veins in their pelvis and have zero symptoms. And the rule is with veins, if they don't bother you, we don't treat them.
You leave them alone.
We leave them alone. So if you go and have imaging done for something else, let's say you have fibroids, and you have imaging done for fibroids, and they happen to find dilated veins in your pelvis, if you treat your fibroids and you're feeling fine, don't worry about it.
Yeah.
Your veins may never bother you.
Don't touch it.
So, so pelvic congestion syndrome. Pelvic pain, pressure, heaviness, pain in your pelvis if you've been standing all day. Basically, just like in your legs when you have varicose veins and the blood pools in those varicose veins in your leg, the blood will pool in the veins around your uterus and your ovaries. And that's why you'll feel pelvic pressure. And just like, when a patient comes in for varicose veins with me, my question is, how do you feel in the morning when you get up? Do your legs feel okay? How do they feel at the end of the day?
Yeah.
How do they feel if you've been standing a long time or if you've been sitting a long time? It's like the same questions for pelvic congestion. Yeah. Like, especially, depending on your occupation. So like teachers will get varicose veins because they're standing all day. So if you're a teacher and by the end of the day you're having terrible pelvic pain, you can have pelvic congestion syndrome. So it's the same thing. Who's at risk for pelvic congestion syndrome? Women of reproductive age. They're at the highest risk. Women who've had multiple pregnancies. Hormone cycles. So you get your period, you have a surge of hormones, you get engorgement with your menstruation, and then it subsides. So it's like that hormone cycle, and just like as your varicose veins, unfortunately, I tell patients when they have venous insufficiency that it becomes a lifelong kind of situation because your veins are prone to failing, and then, Now with pelvic congestion, if we treat it, we have excellent treatment rates, so you may never need to be treated again. Unfortunately, a lot of times when people get venous insufficiency in their legs, once we start treating, it's just like you have to keep, treating your veins that fail. So, but however, even though pregnancy and multiple pregnancies is a risk factor, it can happen in women who have never had children before. So,
would that be because of like genetics or?
Yeah, it's a genetic predisposition. So, but what happens is, they're going along, everything's okay, and then they'll go through puberty, and then they have that surge of hormones, and that affects the veins, and then they'll start getting the pains. Or they'll start their menstruation, their period, and then all of a sudden they'll start getting the pain again because of the cycle of the hormones coming and going. So, so how do we diagnose it? So we have like kind of a standard, that we ask patients, like the questions that I ask patients, because they have to kind of meet criteria. Because like I said, this is not commonly recognized or even known about by other physicians. And we do get like pushback from insurance companies and stuff like that.
Yeah.
So there's kind of a criteria that patients need to fall into before we can kind of call it pelvic congestion syndrome. So those criteria are dull and aching pelvic pain for more than 6 months. Mm-hmm. Pain that worsens when you stand for long periods of time. Pain that worsens during your menstrual cycle. Pain. Now, you don't necessarily have to have every single one, but like.
Yeah, they will be.
Right. So, pain during intercourse. Pelvic fullness or heaviness.
Damn.
Imagine.
Yeah, I know.
that all the
Damn.
time. And then a huge symptom that people will talk about, but is not necessarily. See plenty of patients with pelvic congestion who don't have the symptom, but when you talk about other doctors, they'll be like, "Oh, but she didn't have this, so it can't be that." Vulvar varicosities or thigh varicosities. So, I mean, you know what a vulvar is, right?
No, I don't know what vulvar, but I know the other one that you said.
The thigh varicosity?
Yeah, that's so I'm guessing vulvar has to be around.
Yeah.
It has to be around there.
It's your groin. Basically,
Okay,
like varicose veins in your groin are very, very high up on your face, which is not a common place to have them.
Yeah.
You know, usually when we see varicose veins, it's in like lower leg or the thigh or whatever.
Yeah.
But this is really high up. So, and people will say, well, the patient didn't have those, so she can't have pelvic congestion syndrome. Yes.
Yeah, it can be deep, right? Like,
well, yeah, it just means that it hasn't, those veins haven't failed yet. It doesn't mean that they don't have it just because they don't have. It is a symptom. Like if a patient comes into me and she has like varicose veins really high up like that, she may not have any of the other symptoms, but I know that she has pelvic congestion syndrome or a pelvic venous insufficiency from the varicosities. But I'll ask the patient, I'll say, do you have these symptoms? Do you have whatever? If they say yes, then, we'll explore it and we'll talk about it. But if they say no, I leave it alone. Because again, if you don't have symptoms, we leave it alone.
Now, what would be like the best way, like what test would be like the MRI or ultrasound would tell you?
So, the gold standard is venography. So how we diagnose it. So here's the problem. Again, if it's not on a doctor's radar, they're not going, you have to, so when I send somebody for an ultrasound, say I'm working up fibroids are pretty like, boom, you put the ultrasound probe down, and you're going to see the fibroids. Unless I'm suspecting pelvic venous insufficiency, and I write down on the script, I need you to specifically look for this.
Yeah.
They're not going to look for it.
I was just trying to think, like, if you go and get a pelvic exam by your gynecologist, they wouldn't see it.
No, they wouldn't see it. It's not, unless you have varicose veins
popping up on
your vulva or in your upper thigh and your groin. That's not going to trigger, somebody go, oh, okay. So that's why if a patient comes to me and if they don't have imaging done already, I'll send them for an ultrasound. But usually we have to start with an ultrasound because, again, the insurance companies want you to start with that first. And we have to make sure. So remember, differential diagnosis. Why is pelvic congestion syndrome overlooked? Because it can mimic other
symptoms.
Did you hear a noise?
Exactly. Yeah, me too.
Yeah, I was like, oh, who's there? Hi. Come on in. Endometriosis, fibroids, IBS,
IBS,
bladder issues. Right. So all of these, can mimic. That's in our differential diagnosis. So that's why when we do imaging, we have to target to what does it look like? What do you mean? What does it look like? What does it look like on the scans? Oh, okay. So it looks like on MRI or a CT scan, it looks like big, twisty, dilated veins in the pelvis around the uterus and the ovaries. On ultrasound, so you have to do maneuvers. So patients usually have to stand and do Valsalva, which is like using the pressure and whatnot. So again, ultrasound is kind of like, I'll do ultrasound and I'll put it on ultrasound, but they may not necessarily do the exam correctly. But it's more of like, oh, okay, you have pain, but you don't have fibroids, so let's explore, But I'll usually jump to an MRI, and an MRI is really will give us it's not radiation, it'll give us the best imaging, but the gold standard is a venogram, which means I go in and I inject veins contrast directly into the veins, and I look to see, it's called refluxing. So when your veins are not working properly and the valves are not working properly, it's called refluxing. So if I inject, so I had a patient who I was doing a procedure on, and I injected contrast into the veins that I suspected were not working properly. And when you inject contrast into the vein, it's supposed to immediately go back to the heart. If it doesn't, if it hangs out
Yeah.
and just kind of sits there, that means you have reflux. Your veins are not working properly. Right?
Yeah.
Because it's supposed to
It's supposed to
immediately
really
wash
wash
away
out.
and go back to the heart.
Yeah.
So if it doesn't, that means your veins are not working. So that's why venography, if all else fails, some physicians will jump straight to venography. But I like, not that it's invasive, but it's more invasive than an MRI. So I'll do an MRI first because that's less invasive for the patient, So, but if that doesn't give us the answer and we're still suspecting, then I'll do venography. So,
Got it.
and then how do we treat it? Right?
Yeah.
Conservative, NSAIDs, pain medicine, hormone suppression in some cases can work, but we can do what I do.
Procedure.
Yeah, procedure. So minimally invasive. We do it's called. So there are different reasons for the pelvic venous insufficiency. So it could be because the gonadal veins, which are called the gonadal veins in men, they're also called gonadal veins in women, but they're also called ovarian veins in women. So we'll do ovarian vein embolization. Those are the veins that carry the blood from your pelvis back to your heart. When those fail, they back up all the veins and they back up into the pelvis, and that's what causes all the discomfort. So you can have pelvic venous insufficiency or pelvic congestion syndrome because the failure of your gonadal veins or ovarian veins. You can have it because of the failure of your internal iliac veins, which are the veins that come off of your common iliac in your pelvis. Or you can have what's called nutcracker syndrome, which your renal vein sits between your aorta and your superior mesenteric artery, and it gets squished like a nutcracker. And when it gets squished like that, with the way that our anatomy works, it backs everything up into your pelvis. So those are the three different causes that all lead to pelvic venous insufficiency or pelvic congestion syndrome. The most common is the gonadal veins, the failure of the gonadal veins or the ovarian veins. So usually what we do is that's what we attack first. However, I had a patient recently who that wasn't the issue. The issue were the internal iliac veins. So we didn't touch the gonadal veins. We let those alone, and we just took care of the internal iliac veins. But either way, it's an embolization. So we embolize that, and so we shut them down so that the blood can't pool in them anymore. And the pain and the discomfort, everything goes away. And so it's minimally invasive. It's what I do. It's a catheter-based procedure. So we go through, make a little nick in your skin, and we can either go through the jugular vein in your neck, or we go through the vein in your groin, whatever, depending on what we need to do, where we need to go. Outpatient procedure, it gets done in the office here. Noodles will bring you snacks afterwards while you're recovering.
You tell me what you want, I got it.
So we have snacks and beverages for you. You recover with us for a little while, make sure that you're doing okay after the sedation, and then that's it. Sometimes surgery. Surgery is for if you have nutcracker syndrome. We have, there have been experimenting in the past putting in stents in order to keep the vein open. Right. But right now, surgery is still kind of the gold standard for that. So they'll transpose. They basically, they take it out from under and they go over. They make like a byway.
Got it.
Sense. So. Yeah. So, benefits of embolization, minimally invasive, no major surgery. Excellent success rate. 70 to 95% of patients get improvement of their symptoms after a good embolization. Same day procedure, fast recovery. And again, so it is covered by insurance.
Yes, it is.
I might have to fight.
Yeah, I was going to say we can't fight for it though.
Sometimes we have to fight for it, but
it's doable.
Yeah, it's doable. A lot of insurances, you don't have to fight. Some of them you do, but we get it done because, I won't give up. I'm a tenacious little Italian. So is Skittles. Abby is too. I don't know why Abby is hiding, but Abby's strong. yeah, we get it done because,
no one wants to be in pain. It's not fair.
it's not fair.
I'll fight anyone.
Yeah.
I will.
Noodles is taking
You're
your
not
earrings off
gonna.
of me.
You're not gonna mess with me. I know where you live. I'm gonna tell you something later.
Off camera. Off camera. Everybody's like, we want to hear about that. Stop talking about pelvic congestion syndrome. We're bored. Anyway.
Go to cops. No. It's not that serious. We gotta make the story like kind of interesting.
We're located at. No, I'm just kidding. No.
No. Tell me what
Where we're located. It's all link in bio. They can look the address up.
come when I'm not here.
Okay. Mondays and Fridays. All right. So if you come to the office, obviously the way that I approach things are a lot of times patients will come and they've already gone through a lot of stuff. So they come to me and they may suspect that they have the pelvic congestion syndrome already, or they may not have a clue, or, somebody suggested another physician and she went whatever. So, when you come to me, we'll do a careful physical exam and a history. I'll review imaging if you have imaging. I'll send you for imaging that you need imaging. Of course, we do a lot of patient education here, tell you your options, etc. Answer all your questions. And so, facts. Let's talk about some facts. Is pelvic congestion syndrome dangerous? No, it's not life-threatening. However, what we talked about is
It's really annoying to have it.
Yeah, it severely impacts the quality of
Your life.
And so, people will go through different diagnoses and the pain's still there. And of course, it's terribly frustrating and upsetting. Can pelvic congestion syndrome come back after treatment? Yes, it's possible. Like I said, unfortunately, veins, once you start the fight, it's a lifelong fight. Not necessarily 100%, and it tends to be the legs tend to be worse than, but if these veins fail and we fix those, could the other veins in that area fail later on? Yes, but can we retreat? Yes, absolutely. So that's the beauty of minimally invasive. We can go like even fibroids. If I take care of your fibroid and you're very young, can you theoretically grow more fibroids before you hit menopause? Course. Yeah. And so we can always do a repeat UFA. And so we talked about, does birth control make veins worse? Well, yes.
Yeah, I was gonna say we went over it.
Yeah, we went over that. So
it does.
Yeah, so that's pretty much it. So hormones play a big role in our vascular health. We don't realize it, but it does. Pelvic congestion syndrome or pelvic venous insufficiency is a very real, very treatable condition in women that unfortunately is missed too often because, like one of our viewers said, their primary care physician had never even heard of it before.
Yeah.
And so, if you're a woman out there and you are suffering with chronic pelvic pain, you've gone through all the diagnoses. Maybe you've been worked up for endometriosis. Maybe you've been worked up for fibroids, worked up for IBS or even bladder issues, and nothing is answering your question on why you have pelvic pain or why you're suffering. It could be, pelvic venous insufficiency or pelvic congestion syndrome. And so, if you are somebody out there who is suffering and you don't know, and if you think this might be, like I always say every week, DM me, send me your questions. I'm happy to answer them however I can. If you're in the area, you can come in and make an appointment. We can do a consult and I can try and help you out. If I'm not the right doctor for you, I will always try and send you to someone who is. So, I guess that's it. I think that's it for this week. Ooh, did we talk? We talked a long time. So, tell me, Noodles and Abby, who's hiding?
Welcome back from some being addressed.
Yeah. Being addressed directly. There she is. Oh, it's Abby. Do you guys have any questions? Is there anything that I talked about that you're confused about, or any other questions, or anything like that? No?
You answered all my questions.
You answered questions. She's a kid. All right, I guess we're good. Oh, what happened? Why did the lights get all weird all of a sudden?
Oh, it's because I came in.
Oh,
I just
that
brightened up the room, guys.
Oh, there you go. She's already,
She's already hanging out with me too much.
Tiffany was walking, so Tiffany was gone for 2 weeks. And then she comes back here, and I was like, "Oh, doesn't this hallway look dim? Like there's something about the lights?" And she's going, "Because I wasn't here." Sunshine, so this is what I deal with, guys. Anyway, no, I love you. All right, so that's it, guys. Thank you so much for joining. That's another episode of Live with Dr. S and Noodle and Abby. If anybody has any suggestions for nicknames for Abby,
Yeah, we have to come up with a nickname.
it has to come to me organically.
We gotta do something.
We'll do a check-in every week, guys.
I'll
On TikTok
come.
Live. We'll see
It
if
has
I
to
get
come to me
anything.
organically. So, what should we talk about next week? Do you guys have any ideas? Any yearning, burning questions?
Oh, it's not
No idea.
Usually we try and decide before we end, but I don't know.
What can we talk about?
I don't know. We could talk about hemorrhoid embolization.
Okay, we can do that.
You talk about hemorrhoid embolization. Hemorrhoids.
Yeah, why not?
Include the gentleman in the conversation.
very
Yes.
very inclusive.
And then I'll think about something for skincare. Or maybe we'll just do hemorrhoid. I like to do a combo though.
Yeah.
Yeah.
We can do that.
If anybody has any burning questions that you want me to answer, again, DM me. All right, everyone. From IOR Interventional Vascular Care.
Noodles!
Abby.
We got a toodles. All right, cats and kittens. Good night. Have a great night. DM me with your questions. Bye.